Hello, I'm Mike Porath. I'm going to be your moderator for this session, which is on the Global Commission to End the Diagnostic Odyssey for Children with a Rare Disease. Now, that is a long title, but it fits the long odyssey that many of us are on to help ourselves or our children get a diagnosis for a rare disease. So just a little background about me, and then I'll introduce some other members. I consider myself a patient advocate more than anything else. I have a daughter with a rare disease and three boys that followed her as well, who are typical. I kind of got into the community through that. I spent most of my career as a journalist here in the United States, ABC News, NBC News, New York Times, places like that. Shifted my career to focusing on rare disease, started a health community called The Mighty, which some of you may be aware of, and serve on the boards of the Dupe 15Q Alliance, which is a nonprofit organization that helps kids with my daughter's condition, and the National Organization for Rare Disorders, which is more of an umbrella organization that many of you are very familiar with. Again, what we're trying to do here is really get to getting kids with rare diseases diagnosed much faster. I can tell you from my personal experience that when you get that diagnosis, the world changes. You can seek treatments, you can find community members, you can find specialists. And so what we're really trying to do is, in any situation, in any country around the world, children with a rare disease, getting them that diagnosis much faster. On average, it takes over 5 years, and often over 7 or 8 different doctor visits that they need, different specialists they need to see. So with that, I want to open it up and introduce you to the 3 co-chairs of this organization, which is again, fantastic group that's formed over the last 2 years. So with that, Jan and Greg and Wolfram, please take it away.
Thank you, Mike, for moderating this public session. And it's great when we think about it. Only 1 year ago, when you moderated the first public session, which was taking place at Microsoft headquarters on Times Square in New York, just the day before an event organized on rare disease at the United Nations. And this is when we published the report of the Global Commission just a year ago. So thank you. Wolfram.
Hello, everyone. My name is Wolfram Nothaft, and I'm the Chief Medical Officer at Takeda. Takeda and the Legacy Shire organization have been one of the founding members of the Global Commission about more than 2 years ago. And it's really exciting how much progress we have made and how much we have achieved in the last 2 years, which we will see in the next hour or so. And I was also thinking back about last year, when we had our 1 year progress report in the middle of a snowstorm in New York. And now here we go 1 year later, sitting all virtually together. And it's amazing. And you will hear later also about the technology we are using to leverage that now. And that really brings us all together today. So from Takeda and my personal perspective, it's really, really very rewarding and exciting that we can collaborate with all of you and share our success story. And I really like to thank Jan for including us in this meeting and be part of the ECRD.
And good morning, everyone. Good morning, everyone. My name is Greg Moore, Corporate Vice President at Microsoft, leading health efforts at Microsoft. I'm delighted to be part of the Global Commission with Jan and Wolfram as a co-chair, and to really, and I think you'll see today the power of technology to address what couldn't be a more important area, both personally, professionally, and I think for global technology to have a significant impact together with the medical and research community. Like a moderator, I also have a child with a rare disorder, a first of 5, and this is one that's very personal to me.
Just very briefly, and by the way, we will take questions. If you go to the chat feature, you can ask questions throughout this session. And at the end, I've asked all the speakers to stay on to answer those questions. So there will be a little bit of Q&A at the end of this. So this is just a show you that this is truly a global commission. On this slide, you can see the members of the global commission. It's often the organizations behind them are a big part of this as well. It truly is global. When you look at the folks here, we have people from around the world. We had a 3-hour call yesterday. And I think we had probably people in just about every time zone on that call, dialing in to contribute their thoughts, their experience, all to solve this question of how do we get kids a rare disease much faster. We have it's really a cross section of patient advocates, researchers, clinicians, technologists. Again, from around the world that are helping with this. It's been such a great experience for me to get to know many of them. I've learned a tremendous amount over, again, the last year or two, working with this group of people. When we really talk about the purpose of this commission is to find ways where we can empower the families to, again, give them the tools where they can help get their child diagnosed much faster, and do that by harnessing the power of technology. And that's, when you look at the organizations behind this, Microsoft, Takeda, Eurordis, Nord, many others, you can see them coming together again, and it's really about empowering families and again, harnessing the power of technology. From a big picture perspective, when we look at this, you could go back and see we've got a year one report that we put together last year. You can go to the website. If you Google Global Commission Rare Disease, you'll find it. That actually goes through and it gives you recommendations for what we can do, what our group has recommended. And they're very simple things. For parents, there are, if you've had 6 emergency room visits over the last 6 months with your child, that's a time to maybe ask a doctor, could this be a rare disease? If you've been referred to a couple specialists without getting an answer, that may be the time to ask a primary care physician, could this be a rare disease? So there's actionable recommendations, again, on the website there. And what we want to do today is take you through some of the technology pilot programs that we have put together with a number of different partners. There's a lot of really cutting edge technology here that we think by handing it to whether it's the doctors, the physicians, the parents, that we could, again, help get people diagnosed much faster. With that, I think we want to show you a video where we'll give you it's a 3-4 minute video that gives you really an update on the progress we've made as a group with all the partners we're working with over the course of the last year. And video now.
The road to diagnosis presents one of the greatest challenges, impacting the health, survival, and well-being of more than 300 million people worldwide affected by a rare disease. For a child living with a rare disease, an accurate and timely diagnosis can be the key to a longer and healthier life. In 2018, we brought together experts from around the world with the creativity, technological expertise, and commitment to make a major difference. In 2019, the Global Commission announced actionable recommendations to help and guide the rare disease community.
Foundation 29, a partner of the Global Commission, developed a digital platform, DX29, which it is testing in Spain. DX29 uses artificial intelligence to recognize symptom patterns based on medical records data, patient-reported data, and genomics data. In test cases, the analysis helped lead to a correct diagnosis 79% of the time, and doctors have expressed that they find the tool quite useful. Today, there is a need to make sure that the right patients receive the right referral for an evaluation by a geneticist. We are working to expand telemedicine capabilities that will help improve accurate patient referrals by triaging the patient before they see a specialist, saving time and money. Integrated technologies such as visual recognition technology, smart apps, and best-in-class software capabilities are packaged under one ecosystem that have the ability to be utilized globally and can help reduce the time and costs while increasing quality of care.
The Global Commission is working to develop a common technology framework across its pilot projects to empower other experts working in this field to share learnings and work together to positively impact the diagnostic journey and reduce time to diagnosis. We believe it is crucial for rare diseases to be recognized as an international public health priority with specific policy actions to support and enable the solution pathways. Our goal is to encourage greater collaboration among health and technology experts working to end the diagnostic journey.
In addition to tools for healthcare providers, it's important to focus on families and caregivers to bring them to the front line and empower them. Later this year, we will be piloting an education and awareness effort aimed to support parents searching for a diagnosis. Parents will have their own tools to be proactive in getting a diagnosis for their child.
Our goal is to inspire concerted action and mobilize diverse actors within and outside the health field to work collaboratively towards a shared ambition.
Our vision is the clear path to a timely, accurate diagnosis for children around the world. The Global Commission is taking steps to shorten the road to diagnosis for rare disease patients and ultimately improve the lives of millions affected by rare disease.
We are so pleased to bring this progress update to you, and I'm sure that you can see the potential of these actions and the strengths, impact of the partnership. What is new and great about this there is strong opportunities out there by working together to advance these recommendations and go beyond recommending, but taking actions to have an impact, to create a positive change. And this is how came the commitment to work for the next 5 years. And is that we've tried to define progressively a path to a timely, accurate diagnostic for children around the world. And we know that's a vision, that's an ambition, there is part of an utopia, but the question is how to turn it into a reality. And our approach is to empower patients, families, healthcare providers in order to accelerate the time to diagnose, accuracy of the diagnosis of child with rare diseases, and doing that by harnessing the power of technology together with supporting policy and promoting awareness. So these are the pillars of our action. The Global Commission is working to advance these recommendations along the side of other global leaders in the rare disease field. And progressively, we're trying to contribute to be part of the rare disease international ecosystem. And for that, we can mention obviously the work first of the national actors like National Organization for Rare Disease, NORD in the US, or CORD in Canada, or China, ORD and the Chinese Alliance of Rare Disease, but also in Singapore, in Hong Kong, and in Australia, different parts of the world. But also in this international ecosystem, there is Rare Disease International, with this joint declaration, which clearly focuses all on an entry point on diagnostic. There is the collaboration today of RDI with the World Health Organization, which has also an entry point on awareness and on diagnostic particularly. And it fits into the political agenda of the Sustainable Development Goals of the United Nations and on the universal health coverage. And we want to contribute to that objective, right? To say that to leave no one behind by helping to have access to diagnosis. But last and not least, it contributes to the vision of ECRD, the International Rare Disease Research Consortium, which brings member states from around the world with private partners and patient groups. And this vision of ECRD is to enable people living with rare disease to receive an accurate diagnosis within 1 year after the first contact with a medical doctor or healthcare professional. So that's also an ambitious goal, but that's what we want to bring together the technology and the science advancement together with the power of the civil society and of the private companies to deliver.
So as you have heard from Jan, we have a clear vision, which of course is aspirational and should be aspirational. And you've also seen in the video that we have 3 pilots going on. And from my perspective, it's really important to deliver on these pilots as some kind of short-term to mid-term goals, and really make everyone understand that the Global Commission can produce tangible impact and output. In addition, of course, we also need to look at a longer time horizon. So that's why we have come up with a 5-year objective setting. Collaboration and building a critical network and work to achieve impact and expedite the time to diagnosis, which is really the ultimate goal of the Global Commission. Secondly, we also want to continue to partner and expand our partnership with key rare disease organizations and leaders to develop new standards of practice. And that is in particular leveraging advancements in technology and genetics, which is now, especially in the situation we are in right now with COVID-19, even more so important than ever before. And thirdly, we want to create and support an ecosystem that advances these new models for families and healthcare providers, and also promote healthcare engagement to, again, accelerate the time to diagnosis. As Mike said, we had a Global Commission meeting yesterday, and of course, you know, it's a very unfortunate situation to be now affected by the COVID-19 situation globally. But I think we all agree that this also provides potentially unique opportunity to further accelerate the implementation and adoption of technologies like, for example, telemedicine and artificial intelligence. And that could only help us to further put an emphasis on using all these tools, not only in the Global Commission, but to the benefit to all the patients and the greater healthcare system.
Thank you, Wolfram. Thank you, Jan. So now we're going to dive a little deeper into some of the pilot programs they were referring to. So again, there's a lot of exciting progress on these pilot programs. Again, they are very much designed to accelerate that time to diagnosis. So I'm going to hand it over to Julian, who can walk us through the first pilot program here.
Thank you very much, Mike. In our pilot, what we are trying to do is to explore how, you know, technology can be used to accelerate the process for diagnosis. Diagnosis for rare diseases is mainly an activity that needs, you know, analysis of data, and we have 2 types of data: clinical data and genomic data. Unfortunately, this analysis right now in a global level is just possible in developed countries. If you are living in a small city in Africa, the access to these tools will be pretty much reduced compared with other countries and other locations. We want to explore how artificial intelligence in general and machine learning in particular is able to accelerate that process using this technology, analyzing the clinical data of the patients, and also analyzing the genome, the genetic information from the patients. Because using these tools, our main goal for this pilot is to make the diagnosis democratic in a way that every person will be able to access to these technologies. Right now, we focus in the last year in creating this tool called DX29 for clinicians. And right now we are, evolving this tool to be able to be used by patients, because the patients, they can contribute to the process of diagnosis. They know about the disease they have. They know about the symptoms they have. And our goal is put together patients and clinicians working together for the same goal, which is providing diagnosis. In the next months, until the end of the year, we are going to make a strong commitment with the community, because we want to diagnose with our tool, just with our tool, 100 people. We want to make this tool real, really real, and we want to put this indicator as a measure of our success. Thank you very much, Mike.
My apologies, had to click my microphone. Hope I'm coming through live on the sound now. Pilot 2 is actually a simple fix for a way for physicians to communicate about patients that they may have concerns over. So it's basically a triage application. So a care provider in the community can rapidly send visual information and questions to a specialist provider pretty much anywhere, asking if the patient should be worked up, what might be some good next steps, what would be the best benefit for the patient there. We're piloting this at Children's National Hospital in Washington, D.C., partnering with NORD, Sundown Solutions, and the Global Commission, of course, as well as Takeda on this. The software is about to undergo its proof of concept trials with physicians in the community. It will be available. We're going to be hosting it with Microsoft and Microsoft Teams, as well as having the phone applications for the providers out there. Very exciting for us. We're hoping this will reduce the time to visit for patients and also engage patients earlier in the diagnostic process so that they can get best care, best outcome. So thanks very much, and we look forward to getting this out there to you.
Okay. Hi, everyone. Just as a quick introduction, so my name is Matthew Osmond, and I'm a genetic counselor at the Children's Hospital of Eastern Ontario in Ottawa, Canada. And so I'm going to give a bit of an overview on the pilot project that we've been working on here in Canada for the last year and a half. Again, following that trend of using advancing technology, and especially taking rare disease patient and family experiences and helping use that to accelerate the time to diagnosis. So just as a bit of a background, while 10 years ago, when rare disease patients and family members were looking for diagnoses, we could look at maybe one to a handful of genes at a time. And 10 years later, we now have the ability, through a test called genome-wide sequencing, to look at all of the genes in someone's DNA, so 20 to 30,000 to give you an idea. And so while this is the best test we've ever had for rare disease diagnosis, analyzing that large amount of data, it really requires a good understanding of that patient's clinical signs and symptoms, which we also call a phenotype. So in the clinics today, these phenotypes are generally given by the clinicians or the geneticists who are involved in that patient's care. But we at the Global Commission know that patients and family members with rare diseases are often highly motivated, and they become experts in their own condition. And so we think it's really important to harness that experience to try and improve the diagnosis and maybe improve our ability to analyze these massive amounts of data we're able to generate now. And so that's where our pilot comes in. We're trying to evaluate what happens if we use the patient-reported or the family-reported phenotypes as the way to interpret this genome-wide sequencing data to get a diagnosis for rare disease patients. So just to examine our objectives a little bit further, we are also developing a tool which is focusing on collecting this information from patients and their family members directly. And so just as a progress update, we've developed a pilot study and we've piloted it out to a small group of rare disease patients and family members. And we're now taking that feedback and implementing that before we start to release the survey out to a larger population. From there, obviously, we have to evaluate the tool. Is the information we're collecting actually able on its own to get a diagnosis through genome-wide data? And how does that compare to when we do that analysis with the clinician data? Finally, we want to look at the combined approach here. If these independent analyses on their own can't come to a diagnosis, can we combine the information from the clinic and from the patient together and get a diagnosis that way? So just a quick overview of how this research is going to work. We're basically going to have two analyses happening in parallel. So on the clinical lab side, they're going to be using the clinician's reported phenotype. And on our side, the research lab side, we'll be using the patient's reported phenotype through the survey that I talked about on the last slide. We'll also be using the same raw genome-wide sequencing data that's generated on the clinical side. We'll bring that back to the research side, and we'll have these two analyses done in parallel. Basically, we'll look at, with the clinician reported phenotype, interpreting this data, what's the outcome there? What is the diagnostic rate of that? And on our side, what is the diagnostic rate when we use the patient's phenotype? And compare and contrast and see which ones work well for what situations. As I mentioned, the last approach we'll have is if either individual process doesn't work to get a diagnosis, we'll combine that phenotype information together, do the analysis again, and see if there is an additive approach to this analysis. That's all I have for this quick update. Just wanted to say that this has been a lot of work from the Care for Ourselves team in Ottawa, the development team in Toronto, Canada, and of course, Eurordis has been a big help with hosting the survey online through Rare Connect. So thank you all very much.
Hi, everyone. Greg Moore here, back again. Just some amazing demos that we just went through, and it is fantastic to see the progress as a new member here of the commission. You know, as we had talked about earlier, we are developing a technology framework, one that is consistent, one that is based on interoperability and indeed global standards such as FHIR, the Fast Healthcare Interoperability Resources. We've developed a key draft framework for this. We've vetted this framework and finalized these standards with not only members of the Global Commission, but members of the international community, and look forward to next steps as we continue to review these standards and then publish and distribute these standards, not only within the Global Commission community, but to others around the globe. So just want to thank everyone for this work here, and really excited about this framework that we've established for this community.
Thank you, Greg. So one of the Global Commission's initial report recommendations is really to better empower the patients and their families on their journey to find a diagnosis. So the challenge that as we met and discussed and brought other folks to the table around this as well, is, you know, one of the biggest challenges is that both parents and doctors are typically not looking for a rare disease. I can tell you my own journey, 2.5 years trying to understand why my daughter was the way she was and how do we help her. The words rare disease never came up in any conversation with any doctor. We weren't thinking about it as parents, and the doctors and specialists we were seeing weren't thinking of it either. So when we think about how do we empower patients and families when do you ask the question, could this be a rare disease? When do you ask the question, should we get a genetic test? From a doctor's point of view, when do they look at something and say, these symptoms really don't add up? Or, should we consider that this may be something that I haven't seen before or someone else may not seen before? It's, where we recognize what the problems and the challenges are, but we have to get this information in the hands of patients and families and doctors. And so what we want to talk about in terms of solutions is an awareness campaign. So we've come together, and again, I think we've got some great advice and recommendations of how families can approach it, how doctors can approach it, but we need to get these in the hands of those folks. And so, Pam, if you can take it away here and talk a little bit about the awareness program and how we want to get this, again, in front of so many more people so that they can ask the questions and they can start digging in on these potential solutions much faster than they may be today.
Hi, yes, thanks, Mike. This is Pam Gavin, speaking to you on this rare sunny day, spring day in Massachusetts. The campaign that the Commission is embarking on is really focusing, as Mike said, on those parents and caregivers of children who have a medical issue, an unexplained medical situation that they are seeking answers on. And so that's the group that we're targeting on this campaign. And the idea is to reach them as early as possible in this journey so that with various educational materials and tools to help what would be disrupting a very long and arduous process to get answers. And the idea behind this is to use various digital channels to reach these people along their current journey, and as early as possible to promote the thought, as Mike said, of considering when your child may have a rare condition, and empower parents and caregivers and clinicians with discussion questions to engage and accelerate that interactive discussion to try to get better answers, to ask better questions, rather, get better answers early on in the process, and hopefully disrupt what is a long, arduous process. The approach that we're taking is a multi-channel campaign, the content of which is really driven by a process engaging a partnership with medical experts on the Global Commission, and then local patient organizations that will be involved in the process early on to ensure that it drives that effective conversation that I just mentioned. The approach, as you can see from the slide, is to use a multi-channel approach to find people where they may be, to present to them the right message at the right time, to disrupt that process as it has typically occurs. We plan with the campaign to do it in a phased approach, to pilot, gather information, learnings, adapt and incorporate those learnings into the next phase of the next set of pilots, and improve as we grow. So stay tuned for more as this awareness program evolves and launches in its pilot phase. Thank you.
Right.
So the path forward here, as we've as we've seen, is based on a solid data foundation, based on technology, including AI, including analytics, with a deep partnership with the caregivers and their families to get them the data and get the data they need, not only their caregivers need to their families, and to make sure that flows and is not siloed. Being both a physician and a scientist, I can't, and even in the evaluation of patients, you all know that they bring thick folders full of data and to those evaluations. And the platforms that we solve today can make that data liquid and keep it private. And this engagement and the tools that we've seen can really, we hope and expect, to speed diagnosis and care and even treatments for our patients. So delighted to take questions at this point with my co-chairs and the others on the team, and excited about this amazing path forward to deliver this next generation of technologies and diagnostics and platforms to our caregivers and patients on this global commission.
Thank you, Greg. I really would like to express our gratitude to Takeda and to Microsoft for the continued support and growing support to the initiatives within the Global Commission. And that's really leadership and generosity, I think, and corporate social responsibility. I'd like to express also the strong commitments of both UORDIS, Rare Disease Europe, and of Rare Disease International with its members around the world, which are both either national alliances across Latin America, but also Nord in the US, Quad in Canada, and across Asia Pacific with the colleagues in Hong Kong, in Singapore, in Malaysia, in Australia, but also South Africa, Ghana, and other countries. So we're going to continue to engage them and even engage them progressively even more into the empowerment campaign, the awareness campaign, but also in presenting them and asking feedback on the different pilots. So progressively engaging more the patient community on understanding the challenges and seeing the opportunities of these new technologies and pilots being developed. The key role that the patients' organizations plays into the Global Commission is clearly around policy, promoting policy recommendations and trying to implement policy pilots in order to translate some of our ambition into actions in the healthcare system, but also into policy actions at the national, regional, and international level, as we need the innovation, we need the legislation, we need the data, we need all these elements to move toward a faster diagnosis and a more accurate diagnosis. I hand over to Wolfram.
Thank you, Jan and Greg. First of all, I would like to thank everyone again. I mean, it was a terrific presentation. Thank you very much for the presenters and contributors. And from my personal perspective, as I mentioned, we've been a co-founder, but for me, it's really a privilege to work with all the members on the Global Commission. And it's a humbling experience, right? There's a lot of enthusiasm, commitment, and dedication. And it's always inspiring to work with this commission and really see how we all work together to bring this agenda forward and to define a vision, as Jan shared with you. So it's really a fascinating journey. And I think even beyond that, we need to think how it not only helps us as a rare disease community, but how we can also leverage everything we learn to the benefit of the broader healthcare community. As you've seen, there are a lot of technology approaches, a lot of the behavioral changes of the collaborations we want to implement. And ultimately, that goes beyond the rare disease community. So hopefully, we can leverage that to the benefit of all patients and instill the spirit on a global level. So to finish, before we move to the Q&A session, and Mike is going to take this on. Again, thank you very much for all who helped to make this possible. And thank you very much to everyone who has been listening in. And it has been a collaboration, and I think that's the spirit we need to have to move things forward. So thank you. And with that, I invite Mike to open the Q&A.
Thank you all very much. Thanks for everyone who's joined the session. Again, what a critical need to serve families out there who are looking to help their children and are struggling in a lot of ways. And again, I'm very privileged to be a part of this organization that's come together to try to solve those challenges for folks. So I want to do a couple things. One is encourage people to visit the Global Commission virtual booth that is here. Also, go to the website. If you, again, easiest way, just search Global Commission Rare Disease. You will find it. Any reports that we put out there are there. Any progress that we have, we post on that website. Encourage you to share those, with others as well. And again, there's ways that you can be involved and help us get to these answers much faster for folks. So with that, I want to open it up for Q&A. I've got some kind of being fed to me from folks in the chat room. So I'm going to start. And this first question is for Marshall. Are there plans to link Pilot 2 to CPMS? It might be good to.
So Pilot 2, we're actually going to link to a number of things. The first bits of Pilot 2 will really be just for communication between community providers and specialists. So it's like a lot of these things, we want to crawl, walk, run. So our crawl is we make it so that providers can reach specialists faster, get their patients in the groove. Walk is we then start to link this to other data sets, other databases. So the specialist actually now can receive data with the patient's permission, and all of this has to occur with the patient and family's permission, from these other data sets that are pulled. Both Projects 1 and Projects 3 will also really, I think, eventually integrate with this. But I think for me, what I really want to do is let's get a win on the ground. Let's get something that's really going to move this forward. But yes, eventually we can link with all these things.
Great, thank you. Question 2 comes from Debbie Drell. Hello, Debbie. She says the diagnosis delays are not only a product of the clinical lack of access to technology, but patients' access to expert physicians. Is there a component of the Global Commission that addresses social determinants and access to quality care from communities that are so-called left behind? And she says, hello from Washington, D.C. This program is so exciting and innovative. Who wants to address that question?
App out that we did is actually to get into areas where there are not physicians, where there's not expertise, whether it's in North America, whether it's in Africa, Latin America, Africa, Asia, take your pick. The nice thing, electrons are fast, and if we can get expert opinion to providers anywhere on the planet, I think we're going to accelerate the process. But there are a lot of places that currently have no access at all.
Does anyone else want to follow up?
Go ahead.
No, just building on this coming from Marshall, this is exactly the point, is that, for a lot of cases, diagnosis doesn't need an expert, right? We are creating, the decision support tools for virtually every physician worldwide. The experts are needed. They are going to be needed because they are complex cases that they are not able to be solved using the tools that we created. But the idea is, if you want to be global, you don't need this expertise for, let's say, the easy cases. the straightforward cases. But the straightforward cases, they are still an issue in much of the countries. We want to, fill this gap. This is the gap we want to fill.
And maybe I can follow up here as well. I think what we've witnessed over the last 10 weeks is what we thought would take years, much of the world going virtual, not only with advanced technology, but with very basic technology. To put the problem that the questioner was asking, there's 4 billion people on the planet without meaningful access to care. So certainly not enough expert physicians to address even the rare disease community at scale. So part of the technology platform today was to actually equip primary care physicians and non-expertise, and even community health care workers as a next step with some of these support tools to create that access to care. That's a big opportunity ahead of us, and it's one that we'll have to scale. But one is, again, in the last 10 weeks, we've moved much more quicker than we ever thought it would in terms of the ability to provide virtual access. So I'm an optimist here in the technology and the science and the medicine.
Great. Anyone else?
I was just going to say, Mike, from an awareness campaign perspective, we are also taking into consideration underserved populations as well.
Go ahead, Marshall.
So one other thing to think about is we not only have to match patients with diagnosis, we have to match them with resources. One thing we have to think through, and that we've got to work on in a lot of different areas, is yes, we've made the diagnosis. That's great. What are you going to do? Where are you going to go to get the help? What are the resources you have? So in some ways, a lot of it's also inventorying what's available in different areas and finding ways to match those.
Okay, great. Thank you. I'm going to move on to question 3. This comes from Elizabeth Sidarius. Good to engage families, but how are we making the data accurate and measurable? She asked about gene panels and potentially the use of those. And she says, by my experience, the diagnosis can be made with these panels from primary care pediatrics. Do you use the HPO to describe the phenotype? So I open that to anyone who wants to jump in on that question or those questions.
So I can address that last question about the HPO, because I think that was related to our pilot. So the answer is yes, we're using the HPO to describe the phenotype. I guess just quick overview for those who don't know, HPO is referring to the human phenotype ontology. Basically, it's a standard set of terms that's used to describe clinical signs and symptoms. So traditionally, yes, that's what we use to analyze genome-wide sequencing data because it's computer readable. And that's what we will use on the patient end as well. We know that sometimes those terms can be relatively complex. And so to try and improve the accessibility of the survey, patients will actually be given lay language options that then are converted into HPO terms for the purpose of analysis. So I hope that answers your question.
And regarding the first question, how to make data accurate, the approach that we are following is we are considering data coming from patients like patient-reported outcome. It's clinical outcome, but at the end it's a patient-reported outcome. So in the tool that we are piloting right now, the data captured from the patient needs clinical validation from a physician. You know what I mean? Because this validation is important to keep integrity and accuracy of the data.
Okay, great. Next question. The synergy of the tools is great, this person writes in. But since we're talking about children, can you speak more about the safety of data? And again, I open that for anyone who wants to jump in on it. Marshall, you raised your hand.
Yeah, I'll go first. Mine's pretty easy. The way our Pilot and our app is set up, the family has to give consent for data to be transmitted. The data is not stored on the provider's phone, so it just wipes and goes forward, and then the data is stored behind a also we'll be looking at the European and other requirements as well too, and it's housed at a nonprofit which is NORD on their firewall. So we've done about everything we can to ensure it. And the thing is, there's not tremendous amounts of depth of data and a lot of identifiers there. So for Pilot 2, that's not as big a concern.
For Pilot 1, we developed the platform with the support of the legal firm here in Spain to be full GDPR compliance. As Marcel already mentioned, all data capturing process needs explicit consent from the patient, and any data movement from one platform to other, or from one data center to other, needs a specific patient approval. And right now we are using Microsoft Azure with databases in Europe that the patient will be able to, and because of the agreement between US and Europe, we can use data centers based in Europe. But in any case, in the future, this will be open to the patient. We are creating the tool, really putting the patient in the middle, because the patient is the owner of the data.
And I guess lastly, to follow up with Pilot 3, yeah, from our end, the safety of the data and how it's protected is very important. From the standpoint of developing the scientific, the protocol itself, that is done through a research ethics board to ensure that all of the data is stored and accessed in very specific and very secure ways. And from the survey development standpoint, similar to what others have mentioned, it's hosted on, secure servers behind firewalls as well. So we've made a lot of efforts as well to make sure that this data is stored securely and only accessed by those who have authorization to.
Great, thanks. So next question. Making communications more fluid between community physicians and specialists is an easy win, and the current pandemic has opened even those who are reluctant to this to try video consulting. How will you expand this to other countries?
That sounds like maybe.
Go ahead, Marcel.
Yeah, so in some ways, actually, it's almost easier to go international than it is actually to work within your own country, because we have lots of interesting things between states and stuff like that in the U.S. As long as the parents are consenting to what's doing, we can give an opinion. We're not going to generate a bill from it, because internationally that's really hard to do, which you may find some resistance from that. But from the standpoint of going international, we've actually done some of that already just on pilot levels in our own clinical program, and that's actually quite easy to do. So this scales up very quickly.
Yeah, maybe to follow up on that, I'd like to refer to two surveys. One that we did in the last 2 years about the attitude of patients, the opinion of patients and families about sharing and protecting their data. And clearly there is an overwhelm, this 97% of the families who want to share their data in the context both of healthcare and research. What they care for is not the abuse of this data for the social consequences like access to loans, insurance, or work. So it's, from my perspective, everything we're working on in the context of the Global Commission is going in the right direction of making the most of the data and leveraging the digital technology. Now, the second feedback from patients I'd like to mention is the survey we're just doing. It will be completed on Sunday. It's on COVID, on the impact of COVID-19 on the patients and families across Europe and across rare diseases. And based on 7,000 responses, which is significant, we got an overwhelming support for e-health. In fact, what we observed is that before COVID, before COVID, there was only 2 out of 10 patients which were using e-health or benefiting of e-health. During the COVID crisis, it's now 1 out of 2, so 5 out of 10, which have benefited, which is so more than doubling. And that means having virtual consultation, e-prescription, or a new flow of communication between the patient or the parents with the specialist at the hospital, with the local community physicians or pharmacists. And what is interesting is that 9 out of 10, so 90% of the ones who have benefited from e-health are satisfied or highly satisfied. So there is an appetite and a strong support to move in that direction.
Yeah, I wonder, Greg, you actually mentioned something in yesterday's meeting about obviously we have a lot of doctors out there using Microsoft tools, and you have a sense of how that may stick in terms of telemedicine and all that. I thought it'd be great if you might share what you told us yesterday.
Absolutely. So, and even circling back to this last question about how is the pandemic right now allowing to scale, and something that even surprised me, artificial intelligence infused health bots for screening and triage, in this case for COVID-19, but could easily be adapted for rare diseases. Here, just to give you an example how that scaled. So within 4 weeks, that scaled from one healthcare system in the United States, Providence, to now 1,500 healthcare systems across 21 countries, at least 23 as of today, with over 31 million people screened and triaged. That's a scale that happened, in tech terms, literally overnight, and something that opened up immediately, something we thought would take years to happen. So the technology is available to scale, and this is a wonderful way to begin to leverage some of the best experts and their knowledge to bring screening, triage, and even perhaps diagnosis through technology like this. And as I alluded to yesterday, we have really seen the world become virtual overnight. Even now with the as anyone in the community at a medical center knows, most ambulatory visits have been near completely shut down in most healthcare systems. And we've seen now over 30% of those primary care ambulatory visits actually replaced with virtual video consults in this very short period of time. So that's a tremendous scale, tremendous encouragement for the future. And particularly in the rare disease community, just thinking about the number of missed appointments that have happened even over these last 10 weeks and the ability now to scale this. Part of the reason why I said I was an optimist for the future is how I've seen these things scale that have surprised even a doc in tech.
Thank you. Yeah, Marshall, go ahead.
One of the things we're going to need to put together, particularly for international work, is sort of the equivalent of a Doctors Without Digital Borders group. We're going to need to put together some pools of volunteers, of specialists willing to evaluate patients in areas where there just is no other access. And there's some creative ways you can incentivize that too, whether people can get medical education credits for that, if there are different ways to incentivize that sort of thing. But I think we've got to build some back end too, so that as we're pulling all these patients through, at some point when they do need the input from a specialist, we have the group standing up.
Great, thank you.
And
Marshall,
that's so. My only comment is, I think that's a great idea, and as we do that, and expressing some of the other sentiment is as we have Doctors Without Digital Borders, I think we also need to establish, what is a digital medicine Hippocratic oath? Do no harm, if you will, with digital going forward to ensure safety and that we're doing the right thing in a digital environment. We're all committed to that, but sometimes as you push things forward, there can be unintended consequences. And so we need to, community, be sure that we're paying, be looking for potential unintended consequences of this, make sure they're doing the right things for our children and their families.
And Marcia, I thought something you said yesterday as well really resonated with me, kind of got me fired up a little bit. We've all been impacted in various different ways with the pandemic, COVID-19 now. You spoke a little about a unique opportunity, silver lining, so to speak, this presents with the work we're doing here. And I wonder if you would share that for those watching.
Sure. It's an old Winston Churchill quote. It's basically never let a good crisis go to waste. And I wouldn't wish this pandemic on anybody. But one of the things that's come out of it is that we've been forced to make a leap into doing things differently that we otherwise probably would have been very reluctant to do. So, for instance, at our institution, we've done 20,000 telemedicine specialist visits in the last month period across all of our many specialties. We were pushing up towards 1,000 in my group alone on that front. And I think one of the things we want to make sure we do is we don't let the rubber band snap back. As this pandemic fades, what we're finding is this is better for the patients. It's safer for the patients. It means that people who otherwise couldn't take a day off from work, load their kids up into a car and come into a clinic, now can actually be seen in the safety and the convenience of their own home and get good care. There are a lot of new devices available so that we can do physical measurements at home. We can do testing at home. So it's kind of, I think, an opportunity to move these things forward. And I think the commission is beautifully positioned to do this. I mean, about play right into this. Is that sort of hitting what you were asking, Mike?
Yes, it does. We got a couple more questions that just came in. We talked a little bit about cross-border healthcare. There's challenges with things like languages, different healthcare systems, GDPR. Does anyone want to talk about how we tackle some of those issues?
Boy, well, with the increased telemedicine, I'll go right into it. We've used 42 different language translators in the last month. It's an issue. One of the things we'll need to look at long term is, are there either really good, reliable digital translation tools, or can we also, while we're building up our group of specialists, can we also get the translators in there too, to either volunteer or find a way to pull that into the system?
And perhaps I can follow up here just for a moment. So the data does indeed have to travel under privacy, safety, and protected guidelines, GDPR and HIPAA, and the others around the globe. The Microsoft Azure platform has all these tools and about 150 other certifications. Importantly, the data stays within individual healthcare systems tenants. It doesn't come to Microsoft. It's encrypted within their tenants. And I think that's an important policy decision that we've made, so that data stays with various collaborators. Box language translators are over 20 languages at this point, so there's technology available to do that. There'll be you'll see some announcements forthcoming around natural language processing, not only in medical language but to cover other languages, including text analytics, to allow that data liquidity for patients to get data to their providers, and then providers to have the data that they need to take care of their patients. So a lot of work done there. Much of this is around the international FHIR standards, the FHIR Fast Healthcare Interoperability Resources, and HL7 tools that allow easy ingestion for a healthcare system or organization, and then normalization to these across the various silos of data. Other tools like images coming in DICOM even BAM files from Omics are part of these platforms. So there's tremendous plumbing tools to safely move this data around to ingest and analyze.
Thank you. We did get a question that came in, Greg, similar to you were talking about how with the COVID-19, just the speed of adoption in terms of health systems, starting with Providence, in terms of supporting that. There's a question that was here, the clinical decision support tools are certainly very important. However, there's resistance from some health systems to adopt them. So with something like a pandemic, it's obviously going to happen much faster. What approaches do we take to help health systems adopt the tools that we want to create and again, to get people diagnosed much faster with rare diseases?
And I've lived the I'll say pain of clinical decision support tools when I was at Geisinger Health System and designed many of them and to roll them out. So this is not an easy clinical decision support are not easy things to accomplish. However, the area that we're talking about here in terms of rare diseases and children is really helpful in pushing this forward. One is because the expertise is the expertise community is small, and there's a real desire for this expertise to layer in for this decision support. So the appetite could be, in my opinion, higher, and those my colleagues here can weigh in going forward. And this is tough work. So this is system by system work. It's standards work. It's global and international. It can only be done in partnership going forward. The technology foundations are there, and I'd say those are the easy parts of this. I think bringing the communities together on what those tools and those readouts should be, and we'd expect them to actually be different in different geographies and in different areas, just even on the prevalence of the types of rare diseases going forward, and the resources and how to diagnose and handle them in particular geos. And I'll invite my other colleagues. I'm sure there's additional feedback here.
Sure, Pam.
Thanks, Mike. I agree with what Greg said, and one of the other points to make, in addition to that, is for us to be smart and recognize that it isn't just the technology, its existence. That's very, very important. But do we have an environment that lends itself to implementation? Are there roadblocks? Are there political roadblocks? Are there legal frameworks? Are there financial challenges vis-a-vis payment and insurance that get in the way of adoption? And so I can remember the day, I'm going to date myself, many years ago, I was really very involved in telemedicine adoption at Harvard Risk Management Foundation, working with all the institutions that were part of that framework. And it wasn't so much the technology that was the issue, but rather the insurance, malpractice insurance issues. And that as much as that was beneficial to clinicians and to patients, there was a real reluctance to adopt it because the legal framework in which we were operating was not conducive. So fortunately, we've made great strides, and there's nothing like a horrific, unprecedented pandemic to cause us to put other priorities first. But I think this kind of goes back to also full circle around what Greg said and what Marshall said about the elastic band. So we're very focused on ensuring that these great technological advances, regulatory advances, can actually see the light of day, and that there's a pathway politically to make sure that they get adopted.
I didn't say anything. Ditto.
No, that's great. I'll conclude here with this is an easy question that I can get here. The question is, if someone would like to contribute to the commission in some way, how can they express interest? And they can actually, the easiest way is to go to the virtual room that is set up here, and there's an information intake form where we can get your information and how you may be able to help. And I will add to that, you may see on a page on our website, a bunch of names and organizations that are behind this commission, but know that we do include of other people that can help, shape our ideas and shape the reports that we do. We break up into small teams. Not long ago, a number of us got together in New York. We brought other rare disease parents in. We brought marketing experts in to work on the program Pam talked about on the awareness campaign. So we really do try to reach out and bring the community in to help shape what we're doing here at the Global Commission. So I want to thank our co-chairs for really taking this from where we started a year or two ago to something where we've made so much progress. So to Greg and Jan and Wolfram, thank you very much for you and getting so many people in your organizations to really be a part of this and drive this forward. I want to thank all the Global Commission members again for continuing to make progress on the behalf of people with rare disease, and thank everyone here who's attended this session. And hopefully we've answered some of your questions. Hopefully we've helped you in some small way. And if you are interested in helping us make an impact, again, go to the virtual booth and we'll take in your information from there. So thank you very much to everyone involved here, and we're going to get back to work.